Okay, I'll just share the screen. Okay. Very good. All right. So I thought today I would start off. You can hear me okay?
Yes.
All right, great, thanks. Hope everybody had a great weekend. I'm going to go over very briefly drug of the day, Sotalol. We did that the last time we saw Sotalol in this conference, it was 2020. So we have just a few weeks before 2021. So Sotalol is a non-cardioselective beta blocker, and it was actually introduced in 1970 as an antihypertensive agent. And as in the case of a lot of antiarrhythmic agents, it was later discovered to actually be more potent as an antiarrhythmic agent than it was as an antihypertensive agent. The same could be said also. Amiodarone, I think, was initially introduced as an afterload reducing agent, then discovered to have a lot of other effects. So it was determined to be a class 3 agent shortly thereafter. Class 3, we generally mean to denote potassium channel blockade. And it's an interesting drug in that the L-isomer, L-sotalol, is a beta blocker and a potassium channel blocker, but it's a fairly weak beta blocker. And the D-isomer is a potassium channel blocker. And the combination is how we have the drug. So it's always important to remember that Sotalol is not exclusively a beta blocker, despite its name, which would suggest by the LOL ending that it's simply a beta blocker. It is certainly not. So, of course, it is a beta blocker, and it's important to remember that with Sotalol, you get most of the beta blocker effects at the lowest dosage. So we'll go over dosing in a moment, but when we start Sotalol, pretty much are seeing all of the effects that you're going to get from the beta blockade. You don't actually get a lot of the class 3 effects at the lower dose, which is probably why it only works effectively for a lot of patients at higher dose. As you raise the dose, you get the class 3 effects, which results in prolongation in the action potential in both the atrium and the ventricle. And it's important to remember that all class 3 agents can prolong the QT interval, enhancing the risk for possible torsade. And so anybody in whom you're using Sotalol in the first stages of its use, you ought to be measuring the QT interval to confirm that it is within a normal range and not dangerous. And this is the reason why typically when we start this medication, it is not done as an outpatient, it's done as an inpatient. There was a recent paper that I reviewed on the podcast a number of months ago from Boston, in which they looked at patients who had been started in the hospital just to try and get a sense of whether or not there were any patients who they felt could be started as an outpatient. And it was a retrospective review, but essentially what they basically said was something to the effect that if you were a healthy, otherwise well person, probably it was okay to start as an outpatient, but it is still standard to start this agent as an inpatient because of the possibility of QT prolongation to a dangerous level. And this is an example. The dotted line represents the effect of Sotalol on the action potential, lengthening the action potential. And as you know, this is one of these things where a little bit is antiarrhythmic, a little bit more than a little bit is pro-arrhythmic. And so a little bit is good, a little bit more is not. Sotalol is an agent that is very well absorbed from the GI tract, more than 90%, and peak serum concentrations are about 2 to 3 hours after the agent has been administered. And the half-life in adults is 7 to 8 hours, and it is shorter in children. And the drug isn't metabolized, it's just excreted by the kidneys, but it's important to remember that when a patient is renally insufficient, they need to have their Sotalol adjusted downward because of this. This is an important interaction, particularly if you're thinking about board examination someday. So renal dysfunction, Sotalol needs to be adjusted. In terms of dosage, Sotalol is dosed per meter squared per day in children. And typically the dose starts at 80 milligrams per meter squared per day, can go up as high as 180 or even 200 milligrams per meter squared per day, divided Q8. And the Q8 dosing was based on one of the very few pharmacokinetic and dynamic studies performed in children. Some of you may be aware that, as you would imagine, it's not to a drug company's benefit to get specific pediatric approval for agents. What they typically do is they get approval for a med for adults, and then we in pediatrics essentially steal it and use it in kids in an unapproved manner. But because of recognition of this fact, the government a few years ago, actually about a decade or two ago, came up with a sort of a law whereby if a company was willing to run a pharmacokinetics and dynamic study on children of an agent that was already FDA approved, the company would be given, I think, 2 or 3 years more of patent protection on the agent, which is worth, potentially hundreds of millions of dollars. And so the company that manufactures Sotalol actually did do that study, and I participated in that study. But the bottom line is, it was determined in that study that Sotalol should be dosed Q8 up to about 12 or 13 years of age, and this was not previously known. In adults, the starting dose is 80 milligrams POBID, and you can increase up to about 160 to 200 milligrams per day, per dose, I'm sorry. Okay. In pediatrics, the most common use for Sotalol, I think, would be for the treatment of SVT. Second most common would be atrial arrhythmias, and then finally, rarely it's used for ventricular arrhythmias. And I just will point you to this paper that is written by Ellis Rochelson over at Montefiore when he was a fellow just this past year at Texas Children's. I'm going to be reviewing it on the podcast this week if you're interested. But it's a nice small study assessing the impact or the comparison between Sotalol and Amiodarone for postoperative junctional tachycardia, because Sotalol has been approved since 2009 as an IV agent. I often joke that it's an agent looking for an arrhythmia, because there are so many other drugs that are effective for most arrhythmias that can be given IV. But I think one of the biggest concerns always with Amiodarone is that it is probably not as effective as people believe. There's actually not a great deal of evidence suggesting that it is very effective, but more importantly, there's a very high association with complications or side effects. In the only double-blind study of intravenous amiodarone, the incidence of serious complications was 87%. These included things like hypotension, heart block, and cardiovascular collapse. Cardiovascular collapse, more recently, in a very large multi-center retrospective study with like 500 kids, happened in 10% of babies who got IV amio. So it is not without its risks. And so the team in Texas Children's recently published this. It literally came out like last week. And what they do is they give 1 milligram per kilo of Sotalol IV over 1 hour. And there were 12 patients who received Sotalol, and I think about 25 who received amiodarone. It was like a 5-year period. And 5 of the 12 patients who got Sotalol needed a second bolus in the first 24 hours, and the average number of boluses was 1.5. And most of the patients just received 1 or 2 boluses, and that was it. But in 2 patients, IV Sotalol was started as a maintenance. And as a maintenance, it's actually not given as a continuous infusion. It's given in a Q8 manner, and they gave 120 milligrams per meter squared per day, which is, of course, a relatively standard oral agent recommendation. And this really is probably the most important, and actually the only really statistically significant difference that they identified between amiodarone and Sotalol, which was that in the first 90 minutes after it was administered, the rate of decrease in the heart rate was substantially greater when Sotalol was used versus amiodarone. Amiodarone had an average of 8 beats per minute reduction in heart rate per hour over the first 90 minutes, whereas Sotalol had a 24 beat per minute reduction per hour over the first 90 minutes. Now, it's important to remember that at 24 hours, the heart rates were the same and between the two agents. But I do think it's at least an interesting study. It clearly, with only 12 patients in the Sotalol arm and 20 some art in the Amiodarone arm, as well as the retrospective study design, it's pretty hard to make any kind of conclusions regarding efficacy or safety, but I think it's certainly intriguing that IV Sotalol might possibly be an agent. And there is, in fact, a study ongoing through the Pediatric and Adult Congenital EP Society, a registry study looking at a far larger number of patients getting IV Sotalol in order to try and figure this out. So I thought I'd mention that. All right. Any questions about Sotalol before we move on to our typical weekly unknowns? I guess not. Okay, let's move on.
Actually, I was just wondering if we could speak for a sec about Sotalol toxicity.
Yes, please. Go right ahead, David.
I was hoping we might be able to go into it.
Okay, so the most important, so interestingly, there was really essentially no toxicity of IV Sotalol in this study. Everybody seemed to tolerate it. The most important finding, I think, of this study, this is, this is a very different, this chart makes it look like Sotalol is far better than Amiodarone. But I think it's important to remember that I think two of the patients in the study, and there were only 20 plus 25 patients who got Amio, two patients got a very low dose of Amio. So in such a small cohort, if two patients didn't have a significant reduction in their heart rate, then that could clearly bias these data quite substantially. I think probably what I would say is any beta blocker can theoretically cause bradycardia. So I think we would have to, I certainly would never consider using this agent given how little we know about it without A and V pacing wires. I think that hypotension, although was not an issue in this study, it's important to remember there were only 12 such patients. Sotalol can absolutely prolong your QT interval, so it's possible that a patient could develop torsade or something like that with it, although I'm not sure it's any more likely than with Amiodarone. And then I think the last, probably the biggest risk is whether it's going to work. I mean, we think it's effective, and this study certainly is highly suggestive of that fact, but we really do not have a lot of strong evidence yet that that is in fact a good agent to be used for this arrhythmia. I think based on this paper, I certainly would not be opposed to trying it. I don't even know if it's on formulary at Mount Sinai, but it, what happened was this medicine was approved in 2009. And I believe that what happened was it wasn't really used very much. And so the company that manufactured it essentially stopped making it. And then another company basically bought the patent to manufacture and market it. And that company is now the one that is sort of interested in people becoming interested in the use of IV Sotalol. So I think I would say probably the most important side effects are the unknown side effects, hypotension, although again, it's important to remember there was none in this study, which makes it seem pretty nice. But whenever I see zero side effects from an agent that I know could have that potentially, it makes me a little nervous that maybe the study sample size isn't large enough to demonstrate that. It's interesting to note that when this paper was first presented, and I was the moderator of the session just this past spring at the Heart Rhythm Society. This was not, the title of the work was not a comparison one-to-one between Sotalol and Amiodarone for JET. It was a general review of IV Sotalol in general. And my suspicion is that the authors decided that this was the more interesting or novel aspect of it. And in fact, I think it is pretty much the first paper looking at Sotalol exclusively for the use of treatment of JET. There have been a number of papers on IV Sotalol showing that it is effective in very, very small sample sizes. Like, typically a paper will have 15 or 20 patients, and 3 of them had JET, and they'll say something like it was effective. This was, I suspect that what they sort of realized was that when they read the literature, there was enough on IV sotalol that it would not have gotten into a high impact journal unless it was a little bit sexier. And so instead, what they did was a retrospective analysis looking at a 5-year period specifically in the treatment of junctional ectopic tachycardia. And that is novel and different. And in fact, it got published in Heart Rhythm, which is a pretty prominent journal. So I guess it was a good decision. All right. Let's move on now to, can you tell me the tachycardia mechanism? And this patient is being right ventricle paced at cycle length 500. And I think I'm going to ask, what am I going to ask here? Why don't I ask Dr. Bonsall if she has any thoughts on this?
Good morning, Dr. Bash.
Good morning, Dr. Bonsall.
As it says, it's RV pacing. So I'm looking at the RV tracing and trying to see the conduction mechanism. Just give me a moment here.
Please take your time. This is not the easiest question, which is why I asked the chief fellow the question. One of the advantages of being the chief fellow is you get the chief questions.
So after the RV is paced, I think I see the first deflection in the his catheter as compared to the other, like coronary sinus or the HRA catheter.
That's right. So I assume, Perna, that you're referring to these impulses. So the first thing to say is, of course, you can't really tell the tachycardia mechanism from this tracing, right? Because first of all, what percentage of children have ventriculoatrial conduction through their AV node?
I don't know the exact number, but
to be honest, neither do I. But it's very high. A very high percentage of children can conduct retrograde through their AV node, and as we get older, I think that that becomes less true. But I think you're right in suggesting that the earliest retrograde A is seen in the His. If you compare this atrial electrogram, so this is the ventricular electrogram, and then this is the atrial electrogram, and if we compare this A to the A's in the coronary sinus, I think it's fair to say that this retrograde A is in fact earlier than the CS's. And of course, that's the way it ought to be normally if we are conducting retrograde through our AV node, because the AV node is closest of all the catheters that are displayed in this tracing. The His catheter is the one that is closest to the AV node. So if the impulse is traveling up the AV node in the His-Purkinje system, we would expect that the earliest retrograde A would be in the His. But can we say that so if it's going through the His, what would be the most likely mechanism? And I told you this patient has a history of SVT. What would be the most likely mechanism, Perna, for tachycardia in this patient?
ORT.
ORT. Now, but I'm telling you the earliest retrograde conduction is near to the AV node, to the His.
Oh, so it could AV and RT, sorry.
Right. It would seem, right, that if you're going retrograde with the earliest retrograde atrial electrograms near to the His, that we would not be going up a pathway, right? More likely we're going up the AV node. Now, the fly in the ointment is you can have a pathway that's sitting very close to your AV node. And so you don't necessarily know if the earliest retrograde A is in the His, that means that you're going up the AV node. How would you be able to tell with ventricular pacing if this was, so I think we'd agree that most likely you're going up the AV node, but you could also
Mm-hmm.
be going up a pathway that's right next to the AV node and is resulting in an earliest atrial electrogram near to the AV node or to the His system. Is there a way with V pacing that you could demonstrate whether this is going up a what we would call a parahissian pathway, meaning one that's very close to the His, or up the actual AV node and His bundle itself? Is how would
Mm-hmm.
you, using V pacing, how could you separate out those two?
So as you decrease the cycle length, and you would see that with normal AV nodal property, you would have, like you would see Wenckebach as you go down on the cycle length.
Right, the ventriculoatrial time should get longer and longer. And in
Mm-hmm.
what setting? Through the AV node or through a pathway?
Through the AV node.
Right, because a normal feature of AV nodal conduction is decremental properties. And by that, we mean that as one gets faster and faster, or as one puts premature impulses in earlier and earlier, it takes longer and longer to go through the AV node His-Purkinje system. So yes, the VA time, which in this case is very short, would get much longer. That's
Mm-hmm.
correct. So 100% credit for that answer. Is there another thing we could do with V
Mm-hmm.
pacing that could also help us distinguish between the presence of an accessory pathway that is near to the AV node versus going up the actual AV node?
So if we give adenosine,
Mm-hmm.
then it could cause a VA block if we are going through the AV node.
Right. And if we were going through the pathway, what would happen?
It would not block.
Right. It would not block. And not only would it not block, if there were a pathway, it's possible that this VA interval is basically a combination of retrograde conduction, both through the AV node, but also through a pathway. So sometimes when you give adenosine, you're right that if there were a pathway, the VA conduction would persist, but the VA interval might change. It might actually get shorter because what we could be seeing here is fusion between retrograde AV nodal conduction as well as accessory pathway conduction. So the most important question is there persistence of VA conduction? If there is persistence of VA conduction in the setting of a very large dose of adenosine, we would generally surmise that this means that there is a presence of an accessory pathway, which, as you said, are adenosine insensitive generally. But the other thing that you might see is a slight change in the VA interval as well. So very, very good, Perna. Good job. All right. This is a 10-year-old who comes to clinic with a history of intermittent palpitations and was heard by the pediatrician to have a slightly irregular heartbeat. So I'm going to ask Dr. David Barris of the Bronx, New York, if he has any thoughts on what we're looking at here.
All right, so I'm trying to ascertain our rhythm here. Looking at our rate, it's about a little faster than 100, which I suppose is okay for a 10-year-old. And now looking at looking for my P wave axis, I see P waves that are upright in AVF, and I see P waves that are upright in 1, but on that second beat in lead 1, I'm having difficulty actually seeing the P wave.
Mm-hmm.
The QRS complex, and I'm kind of shifting my attention to the rhythm strip at the bottom of V1.
Mm-hmm.
And I'm looking for P waves. Again, it's that second beat where I'm not quite seeing it as clearly. There is a downward deflection. And then the character of the deflections look a little bit different as I'm going along the strip. The rate looks kind of regular, and then just at the far right of the strip, there is that irregularity. And I'm kind of trying to figure out whether that's an early beat and then maybe a blocked PAC, or whether this is just, a sinus arrhythmia.
Mhm.
Um,
Let me ask you this.
sure.
So remember that in this particular ECG machine, which is not true of all ECG machines, all the leads are simultaneous. In other words, what's going from left to right is happening, going down as well. So if we look at these leads on this one beat, does this P wave look like that P wave?
I would say it looks different.
What about the PR interval?
The PR interval looks shorter.
It looks shorter on this beat, right?
Yeah.
Yeah. What would you, and then I think it would be fair to say that the tachycardia or the faster heartbeat sort of picks up again. So I think what I was trying to demonstrate here is this patient is in EAT, basically. And what's unusual about it, or what's challenging about it, is, as you correctly pointed out, first of all, the heart rate is not very fast, right? It's only, maybe, I think all of us would agree that for a 10-year-old at rest, probably a heart rate of 110 or so is a little on the fast side, but probably at the upper limits of an acceptable heart rate. But the other thing is, part of the reason you're having trouble seeing these P waves is that they're basically in the T wave to a large degree. And so there may not be first degree heart block, but there is borderline first degree heart block. Now, it's easy to, the key to this tracing is this one beat where the tachycardia transiently breaks, and we have a sinus escape beat, and then the tachycardia resumes again. And what makes this hard also is that the axis of the P wave is very similar to sinus, right? This P wave is upright in lead one, albeit a strange looking and sort of flat P wave. And it's upright in F, albeit a very pointy, somewhat unusual looking P wave. Similarly in lead two, it's got this very pointy appearance. So the axis of the P wave is close to normal. But I think the keys here are that, first of all, we're tachycardic. Second of all, the PR interval is long-ish, although still in the normal range. But then we have this one beat, which looks so normal, with a very normal PR interval, well under 200 milliseconds, whereas all of these P waves are closer to 200 milliseconds. So I think that this patient is basically sitting in ectopic atrial tachycardia, and rarely has sinus beats. So Dave, if you saw this patient in your office for the first time, and when we speak to this patient, the patient says, I don't really feel anything, but the pediatrician heard an irregular heartbeat. So how would you go about evaluating this patient? So you see this and you're a little bit surprised that the patient is actually in this arrhythmia.
I think I would want to get an echocardiogram just to make sure there was no, decrease in function because of sustained arrhythmia once they're in the office.
I agree with that. I agree with that. And let's just say, for the sake of discussion, the echocardiogram was normal. Why do you think the echo would be normal in this patient? Now, we don't know what the burden of tachycardia is, but there's a suggestion, right, that since we, in a single 12-second snapshot, we have a lot of tachycardia. So we have to assume there's a fair bit of this, although you're going to tell me how we're going to figure out how much of there is. Why do you think it is that the echo function would be normal? Because, of course, we're always worried about EAT causing ventricular dysfunction. It's one of the only reversible causes of ventricular dysfunction is tachycardia-induced cardiomyopathy. So why do you think it is, if you saw this, you don't know yet what the monitor is going to show, but why do you what would you surmise based on that echo in regards to the burden of tachycardia?
Well, I would say that in this specific patient, the P wave axis is so similar that we could be having, just normal AV coordination, and therefore it hasn't impacted our function too much. Also, I think EAT is usually pretty well tolerated in pediatrics.
Well, I guess the bottom line is what I'm really trying to hint at is the heart rate. Even if I put a pacemaker in you and I put the atrial lead, I mapped your atrium and I found your sinus node, and I screwed the pacemaker lead into your sinus node, and I paced you at 190 beats per minute all the time. Would you develop cardiomyopathy?
I would say from 190, I would say yes.
Yes, you would. You would get, even though I'm pacing you at exactly the location of your sinus node. So it's not so much the position of where it's coming from, it's really the heart rate. So, I often say that when it comes to EAT or to tachycardia-induced cardiomyopathies in general, the echo is kind of like the hemoglobin A1C, in that it gives us a good sense of what things have been like for a long period of time. And so if you don't have dilation and you don't have dysfunction, oftentimes that's a good indirect sign that you're not going to get a Holter that shows, very bad tachycardia. Now, it's possible that the child might be sitting in tachycardia all the time at a rate of 110, as we're looking at in this tracing. But it suggests to me if the Holter is, if the echocardiogram doesn't show a lot of dilation or dysfunction, it's highly suggestive of the tachycardia not being that aggressive that it causes dysfunction. So you've got the echo. The echo shows good function and no dilation. And so what else would you do with this patient that you're meeting for the first time?
I think that we'd want to put a ZO on the patient just to see how long or how frequent the patient's in tachycardia over the course of maybe a week or so.
Yeah, I certainly would agree. Some kind of ambulatory monitor, anything from a Holter monitor to a ZO to, there's another device called a Barty device, but whatever the device is, you would want to know what the average heart rates are and see if you can figure out how much of the time the patient is in tachycardia versus in normal rhythm. That would be important. And then how would you decide whether or not to treat this?
So I think, kind of speak to your earlier point, I suppose if the rates were high enough that I was concerned that they would impact function over time, that would be an easy indication for treatment. I think if the patient was also feeling symptomatic, as in the palpitations were troubling them, that would be another indication for treatment.
Yeah, I think that's right. Generally speaking, you're right. We would treat if a patient either was symptomatic and was complaining of palpitations, or alternatively, if we saw that there was a lot of tachycardia that wasn't being recognized. In this particular case, the family is deciding upon whether to have an ablation. And the reason is that they are concerned that it turns out that the monitor which the patient had before seeing me, showed a very large burden of tachycardia, albeit a slowish tachycardia, similar to what we're looking at here. And family was concerned that this 10-year-old patient was not aware of the fact that they were in tachycardia. And they were concerned that, she would present or he would present with myopathy at some point. They don't want to take that risk, or at least they're thinking about that. So they were deciding between medical therapy or ablation, but I think they do want to be on therapy. And I actually, if in my experience, in my view, if you see a patient like this who's essentially sitting in tachycardia almost all the time, I would normally treat that because of concerns that we don't really know what direction this is going. Now, is there any blood work you might want to do on a patient like this who's presenting with this type of tachycardia?
So I feel like checking thyroid function would be worthwhile.
Yes, I agree with you. That would be a good idea. And what about a pheochromocytoma? Do we have to worry about that?
I think if the patient was having hypertension or, the other symptoms like flushing or, high temperatures, then that would be worthwhile.
That's right. I think in the absence of high blood pressure, I probably would not do that type of evaluation or those other symptoms you just described. But yeah, I would normally do a thyroid panel in somebody like this. I honestly have never personally seen anyone who came back positive for hyperthyroidism in this setting, but I think it's easy enough to do. And if that were in fact the reason, you'd certainly want to know that, of course. It could be dangerous. Okay, I think with that, I'm going to stop for today. I have a couple more slides, but we'll save them for next week. I hope everybody has a good first day back after the holiday. Take care, guys. Thanks for joining.
Thank you.
Thank you.
Yeah.
Thank you.
Thank you.